Respected dignitaries on and off dais, presenting a video on free jejunum flap. Patient presented with difficulty in swallowing and altered voice and diagnosed squamous cell carcinoma of the post-cricoid and upper esophagus. How can we reconstruct this defect is challenging, and it's truly believe that we have to reconstruct these defects for the quality of life. This is a defect of the total laryngopharyngectomy. Wide excision, circumferential, total laryngopharyngectomy, specimen sent for the histopathological examination. Pre-jejunum flap was harvested as a standard manner. Though we have option stomach full up, but still we are using to reconstruct this type of defect. Let us see the intraoperative demonstration how to anastomosis the free flap with the defect. This is the defect of the laryngopharyngectomy. Anvil is being introduced to the esophageal end. We can see that we can choose the different size of the stapler according to the size of the lumen of the bowel. Once anvil is being introduced, full thickness purse string suture are taken to make purse string around the anvil. Once anvil is placed and suture has been taken, circumferentially, we are using Prolin 30. Once the anvil is introduced, full stapler is introduced from the distal end of the jejunum, and shaft brought out from the end of the loop of the jejunum loop. We can see that shaft fully come out. Once it's fully come out, the lie of the jejunum can be decided before a stapler to be fired. We have to make sure that no foreign body or any tissue come in between two ends of the bowel loop. Once it meet align, the arm, the proximal end of the stapler can rotate clockwise and align that both loop of the bowel, and stapler we can fire. After fire the stapler, we remove the stapler from the distal end of the jejunum. We can see that you can see the good anastomosis between the loop of the jejunum and then upper esophagus. We can check out the donut, that is anastomosis is good or not. This circular ring we are seeing at the anvil point, this also we can send to for the histopathology examination. Microvascular anastomosis was done between the flap vessels, jejunal flap vessels, and we can see the post-operative flap is monitored with the hand and Doppler and jejunum stump color. This is the post-operative follow-up of the upper GI endoscopy. We can see that jejunal loop is viable, and the anastomosis is also clear, and rugosity is there in the jejunum. And this is the second follow-up patient. So important note is that free jejunum has the flap raised through the standard laparotomy midline incision based on the arcade of the vessel like branch of superior mesenteric artery. Inside of the flap with proximal and distal stump. Proximal stump of the defect with jejunum anastomosis through the suturing like purse string suturing. Distal esophageal stump of the defect with jejunum anastomosis through the circular EES stapler, and vessel anastomosis like flap artery and vein with the facial artery end to end and IJV with the end to side. Thank you.